Hi, this is the third and final segment of the chapter Late Adulthood. At this point, we'll take up what occurs in the impaired, those older adults who fare significantly worse in terms of cognitive ability than what is normal. And impairment of cognitive ability is then represented as of DSM-5 in neurocognitive disorder. Now notice in previous editions of the DSM, Diagnostic and Statistical Manual of Mental Disorders, these were referred to as dementias. As of about a year ago, DSM-5 came out and a change in terminology occurred, acknowledging that these cognitive disorders were related to decline of the nervous system and so-called neurocognitive disorders. Now, one category of these would be major neurocognitive disorder. And here the person has suffered a significant and irreversible loss of intellectual functioning caused by brain damage or disease. And major neurocognitive disorder is most common with the elderly, but this could occur with any age group. There are over 60 causes of this. We'll look at some of the most common ones. Now, that loss of intellectual functioning then means that that person becomes dependent on others for a variety of tasks and decisions. This sort of situation, this significant decline of mental ability, is abnormal and pathological at any age. So we would include this as one of the secondary aging type of effects. This is not a normal part of aging whenever it occurs. The DSM-5 also added a new disorder which did not exist before in the diagnostic system. That's called mild neurocognitive disorder. And here the person develops cognitive problems still more than what would be the normal decline in mental function, but yet still able to function fairly independently. Now, what occurs with mild neurocognitive disorder, some people with this stabilize with this mild level of impairment and it doesn't change much. About half of them, though, do go on to develop major neurocognitive disorder, so it does worsen in about half of these individuals. And then others may actually regain cognitive abilities to some extent after being diagnosed with mild neurocognitive disorder. Now, this was included in DSM-5 in order to begin to identify significant decline in mental ability earlier, and also to enable us to study the progress of cognitive decline more readily in identifying it before it becomes a full-blown dementia and major neurocognitive disorder. Now, as we look at the impaired in terms of intellectual functioning, notice that age does make a big difference, and notice that also this chart still has the term dementia on here. In fact, you'll see people using that term probably for a good long time before they adjust to the new terminology. At any rate, notice that at age 70 to 79, only 5% of the population would have major neurocognitive disorder, but by the time you get to beyond age 90, then you're up to 37%, more than 1 in 3. Also note that the most common cause of neurocognitive disorder would be Alzheimer's disease, followed by vascular dementia here in the U.S. And once again, notice that the numbers increase rapidly with age. Now let's then look at neurocognitive disorder due to Alzheimer's disease. And this is the most common cause of major neurocognitive disorder. Over half people diagnosed that this is determined to be the cause of it. And what we have here is a gradual deterioration of memory and personality. Some of the mechanism is known, formation of plaques, clumps of protein called beta amyloid within various parts of the brain, and neural tangles. The axons of neurons become tangled, what they call tau, and then this causes malfunction of those neurons. The brain eventually begins shrinking even more than what is normal due to the degeneration of neurons. Usually the first damage in Alzheimer's disease is in the hippocampus, which is an area that enables us to store new information and information about events that have occurred. And so some of the first indications of this are forgetfulness about recent events. Our current diagnosis of this is about 85% accurate, so we've become better at identifying whether it's Alzheimer's or some other cause of the problem than it was even a few years ago. Risk factors for Alzheimer's include being female, it's more common amongst females, and also ethnicity. The incidence of this is higher amongst those of European ancestry. If we look at the Asian population, considerably lower. Also, age is an extremely significant factor. By age 65, we only have 1% of the population with Alzheimer's, and if people live to be past 100, over 50% of them experience it, so a drastic increase in numbers with age. Genes are also part of the risk pattern. Now, that is entirely true with early onset Alzheimer's, where it occurs before age 50, or begins before age 50, as happens with people who have trisomy 21, what we call Down syndrome. And here it's entirely genetic, and once it develops between 3 to 5 years, it runs its course. Now, on the other hand, late onset, which is the typical pattern of Alzheimer's, at this point, as the person is in late adulthood, genes are a factor, but not particularly 100%. One gene, though, that is very significant in contributing to risks for Alzheimer's is the ApoE4 gene. If a person has one copy of this gene that increases risk for Alzheimer's, that one copy of it increases their risk by 50%. If one has both copies of that gene with the Alzheimer-related allele, then most all of these people develop Alzheimer's by age 90. So that's one of the significant genes. However, Alzheimer's appears to take maybe several different genetic patterns, different combinations of genes may be involved, and certain genes also seem to be somewhat protective of it. So the genetic pattern is rather complex as far as we can tell. Now, Alzheimer's has been divided into numerous stages. For the sake of simplicity, we're just going to look at what occurs in the early stages of it, the beginning stages, and then what occurs as the disease advances. The beginning stages, you see the person forgetful about recent events, misplacing things, not remembering things that were said and done. And you may also see changes to the person's personality. Now, eventually, as the disease progresses, the memory loss may eventually become dangerous. The person might get lost in even very familiar surroundings. The person might not remember that it's too cold to go outside without protective clothing, so it can be very dangerous. In the final stages of Alzheimer's, eventually the person begins really losing their ability to communicate, even to control their body in some cases, and they require full-time care. Even their sense of identity and personality seem to be lost, and so family members find that really hard. They don't even seem to be really the same person as they were previously. Often they don't even recognize family members by that time. If the person actually lives that long, death comes some 10 to 15 years after the first signs appear. That said, most people that develop Alzheimer's will die of other causes before the disease itself completely takes them. Another cause of neurocognitive disorder would be vascular neurocognitive disorder. And here there is obstruction of blood flow to the brain that causes the decline in mental ability. Now, this can occur as a major incident. The person has a major stroke, or this can be a series of repeated mini strokes, what they call transient ischemic attacks, or TIAs. When the person suffers a stroke, what you would see is a sudden cognitive deficit, a sudden change in their ability to think clearly, to reason, to remember, to move and so forth, take in information. And that then after some time might be followed by partial recovery. And so what you get is a series of stepwise losses with vascular dementia. In other words, the person is at a certain level of mental functioning. If you follow the cursor, you maybe get an idea of this. And then suddenly there's a sudden drop in their cognitive ability. There may be some improvement and recovery, but then again, after a time, there's likely to be another stroke and another sudden decline in ability, after which there may be some improvement, and so on. So we might see a stepwise losses here. Now, that's in contrast to Alzheimer's, where the losses are just simply just gradual linear decline. So the pattern would look more like that. Now, in fact, the first TIA, the first stroke or mini stroke, may be a warning sign and in fact indicate that this is going to again recur. The person is likely to have additional strokes in the future. Also a warning sign in that in some cases we might reduce the likelihood of further strokes or postpone them by altering lifestyle or other factors. So essentially what happens in this is there's insufficient oxygen to some part of the brain due to vascular obstruction. Brain cells die and then the damage is done. Now, the immediate symptoms of strokes include that the person has sudden decline in vision, and they may have sudden blurriness, inability to see through one eye, double vision that comes suddenly. Also, sudden hearing loss may be an indicator, as well as muscle weakness or paralysis, particularly if it's one side of the body, but in some strokes actually paralysis may occur on both sides. Also a loss of sensation if the person is unable to feel parts of their body, or if there's a tingling sensation, all the way to complete loss of sensation, and speech difficulties, aphasia, whether that is complete inability to speak suddenly, or whether that might be slurred speech, difficulty getting the sounds out, and then confusion. Now, in fact, if you see a person who you're seeing several of these indicators, that's a good indication that the person is having a stroke, and you should get medical attention for them immediately. It turns out that medications have been developed that can, to some extent, limit the damage that occurs if they're given very soon after the stroke occurs. But as time passes, those medications become less effective in limiting its effects. Recovery from strokes occurs as other neurons take over the function of those that died. Obviously, the ability to recover is limited, and as vascular dementia advances, there is less and less recovery possible. In Asia, vascular neurocognitive disorder is the most common type of dementia. So there's a reverse pattern rather than Alzheimer's there. It's vascular dementia. Risk factors for vascular neurocognitive disorder include high blood pressure, hypertension, arteriosclerosis, where the blood vessels, the arteries are narrowed and potentially can be blocked by a blood clot. And also diabetes is another risk factor for this. We'll just have a brief look at a few other neurocognitive disorders. Frontotemporal neurocognitive disorder, what is seen there is behavioral disinhibition. So the person may do things that they wouldn't normally have done, that they would have they would act on urges that they normally would have prevented themselves. Apathy, a lack of motivation and interest, loss of empathy for others, not being able to consider the feelings of others, loss of social cognition, awareness of how to interact with others, as well as stereotyped or compulsive ritual behaviors. So the person might engage in repetitive rocking or things like that. And also changes in eating habits, dietary changes. Now that's one pattern. Another pattern of frontotemporal neurocognitive disorder would be where there is a declining language ability. It depends upon what areas of the frontal or temporal lobes are affected. Now that said, deficits in memory ability or ability to learn are not primary symptoms of this type of neurocognitive disorder. Moving on to neurocognitive disorder due to Parkinson's disease. This is a situation where Parkinson's disease does not always at first cause cognitive decline. Usually it's when Parkinson's gets into the latter stages of development. At this point, you might see changes in mood, you might see apathy, a lack of motivation. The person might suffer from hallucinations, their personality may change, and sleep patterns affected as neurons that produce dopamine degenerate. Older people with Parkinson's develop neurocognitive disorders sooner than those that begin to show the effects of this earlier. We also have neurocognitive disorder due to Lewy bodies. These are round deposits of protein that occur throughout the brain. And with this particular neurocognitive disorder, we see fluctuating attention and alertness, comes and goes. Motor ability, movement is affected, and the person experiences recurring visual hallucinations as well as REM sleep disorder. In fact, they may experience REM sleep while they appear to be completely awake. Now, in order to prevent impairment and neurocognitive disorder, there are a number of things that will reduce the likelihood of this. One being regular exercise and a healthy diet. This can reduce the incidence of neurocognitive disorder by half. And we can reduce also the likelihood of strokes by treating high blood pressure, bringing that blood pressure within the normal range, as well as treating heart disease and controlling diabetes, keeping the person's blood sugar within the proper range. Also, we can prevent some neurocognitive disorders by preventing the diseases that cause them. For example, syphilis or AIDS at latter points of those diseases can cause neurocognitive disorders. Or prion, you might have heard of the mad cow disease caused by a virus-like molecule. This is one that also causes neurocognitive disorder, which thankfully hasn't spread within the U.S., although there have been some larger number of cases overseas. Also, having the person to engage in frequent social interaction, so engagement with others, helps prevent impairment as well. Now, some have suggested reducing exposure to what we might call normal toxins, things that, yes, are toxic, but that we encounter in small amounts in our everyday environment. This may have some effect, although we don't have strong scientific evidence along those lines. At one point, people thought that maybe avoiding products that had aluminum, like many deodorants do, would help prevent Alzheimer's. However, the scientific research indicated that this didn't seem to increase the likelihood of Alzheimer's, even though Alzheimer's patients frequently had higher levels of aluminum within their brain. It didn't seem to be due to using deodorant. Also, some suggest various supplements that might help improve circulation to the brain and so forth. Again, we need better scientific evidence before we can say definitively if these will work, and if so, which ones. But there does seem to be some suggestion of that. Now, in terms of treating neurocognitive disorders, the first important step would be to obtain a proper diagnosis and to pinpoint the cause of the cognitive decline, because that is then going to guide the rest of the treatment. And then also to take care of the person's overall health. So anything that benefits health in general is going to also slow the progress of those neurocognitive disorders. So exercise, proper diet, and so forth. Then starting appropriate treatment. And again, consistent with proper diagnosis, this might mean altering the person's diet or providing a medication. For example, with Alzheimer's, there are drugs such as Aricept that slow the progress of that disease, although they can't reverse it. They can slow the progress. With Parkinson's, medications that help the body to produce dopamine also would slow the progress of that disease. And then medications to improve mood or behavior also may be beneficial or may be required in some cases. And then exercise as well. benefits. Yes, even people that have neurocognitive disorders. And then social engagement, even if they don't have memory of that interaction with others, or if they have difficulty with it, if we can engage them interacting with others, this benefits them and helps them to keep what abilities they do have for a longer period of time. So there's a list of treatment. Now, next we come to reversible neurocognitive disorder, and probably you're saying, well, wait a minute, didn't you say that neurocognitive disorder is an irreversible loss of cognitive functioning? That's true. Well, what we are talking about here is conditions that appear to be a neurocognitive disorder, but in fact are not, are conditions that can be reversed. Now, these things that masquerade as neurocognitive disorders may be caused by medication, may be caused by inadequate nutrition, alcohol or substance abuse, situational anxiety, temporary illness, or depression or other mental illness. And we'll examine each of these in just a bit more detail. Now, in fact, how do we determine whether the person is suffering from a neurocognitive disorder or whether there is one of these other temporary conditions that is causing the decline in mental functioning? And one of the ways to help determine this is the use of the MMSE, the Mini Mental Status Exam. And this is a series of questions, an interview with the person in which we can assess their mental functioning and find out if it's continuous, which would be what we would typically find in an actual neurocognitive disorder, worsening, or if this is something that is fluctuating and changeable. So the use of this repeatedly to check on the person's mental status can help us distinguish between real NCDs and reversible conditions. Now, in some cases, what appears to be a neurocognitive disorder is due to drugs or medication. Anesthesia, the person is put under anesthesia for surgery or so forth, may cause delirium, and that is confusion and inability to think clearly, fluctuating consciousness, which may appear somewhat like a neurocognitive disorder. This, of course, is temporary as the person comes out of that anesthesia. Now, the thing is that older people also take longer to come out of anesthesia, so that delirium may last considerably longer, or in fact, the person may have this where a younger person might not go through that. Also, we know that many drugs that are taken by the elderly as medications may slow mental processing. And side effects of drugs may be exaggerated in the older person. The side effects may be more pronounced. And for that matter, physicians need to adjust the dosage for the older person. Frequently, that older person needs a lower dosage than a younger person, as their body doesn't wash away that substance as rapidly. And then we have the potential of all sorts of drug interactions from various medications the person may be taking, as well as possibly over-the-counter drugs that they're using. Maybe herbal remedies might come into play also in this interaction sort of situation. All of these things may combine to produce confusion, even psychotic behavior that makes no sense. And it may turn out that this is simply an interaction between a number of things that person is taking. It's obviously very important that when the older person goes to the doctor, that the doctor is made aware of what medications that person is taking. One of my students who is a nurse suggested that when that older person is taken to the doctor, that they take along all of their medications in a plastic bag so the doctor can see what all they're taking. Often older people also are going to several doctors, each of whom might be prescribing something different. We also know that nutritional deficiencies can cause what appears to be a neurocognitive disorder, particularly B vitamin deficiencies or dehydration can temporarily impair the person's thinking ability. Substance abuse can also give the appearance of neurocognitive disorder, and this can be from the abuse of prescription drugs, illicit drugs, or alcohol. And of course, when that abuse is addressed, then the problem goes away as well. Same thing with nutritional deficiencies. Sometimes situational anxiety also can mimic neurocognitive disorder. If a person is admitted to a hospital or nursing home, often that whole process is frightening to them, and they may be given pain medications as well, that they're hospitalized, which also help to confuse and slow their thinking. They may experience in these situations sleep deprivation. In the hospital, they may be woken several times during the night in order to take their temperature or whatever medications. And just being in an unfamiliar situation lends to confusion. So put that all together, and sometimes this causes that person to seem as if they're suddenly developing neurocognitive disorder. In fact, once they adjust to the situation or they're removed from the situation, their functioning returns. Also, physical illness can sometimes also give that appearance. The person that has uncontrolled diabetes, where their blood sugar is way out of range, as the person is older, that impairment may be significant enough to appear like a dementia. Or if the person comes down with infections that also may affect their cognitive ability temporarily declining. And then psychological illness. Now, in fact, what we find is rates of most mental disorders are lower after people reach age 65. And even if that mental disorder is still present, often the symptoms are somewhat alleviated as the person gets older. But that said, about 10% of what appears to be neurocognitive disorder is actually undiagnosed psychological illness. Now, in particular, depression may be mistaken for development of neurocognitive disorder. Depression affects cognition and mental processing. People who are depressed have difficulty concentrating and thinking clearly. They develop a negative bias in their thinking that might not be part of their normal personality, and memory is affected when people are depressed. Now, particularly when people are depressed, one of the indicators of that is their memory for positive events is impacted. They tend to remember negative events, unpleasant events, but not the more positive one. And this is one of the things that can help us distinguish whether this is neurocognitive disorder or whether this is the effects of depression. One of the sad things is that depression often is not recognized in people that are older. People look at that, the person seems down, inactive, and they just say, that's just the way it is when you get old, that's just old age. But in fact, that's not normal. Those are signs of depression even in the elderly. And the other thing that's sad is depression can usually be treated very successfully in the elderly person if, once again, it's recognized. Cognitive behavioral therapy is quite effective even with people up in years. Medications too might have some effectiveness. So it's kind of a sad situation where you see that elderly person suffering from depression and nothing is being done about it. Oh, and I should mention also, in the elderly, an important part of treating depression is getting them active in interacting with other people. and getting some activity on their part as well. So that also would be an important factor there. Now, let's shift now from what is worse than the typical pattern of cognitive development to what is optimal and sort of, best possible scenario here. And in fact, new cognitive development, new thinking abilities are possible. Now, Erickson looks at the developmental challenge of late adulthood as integrity versus despair. So you see, this older person is going to strive to get a sense that their life had purpose, that it all fits together, that it made sense somehow, that it was all for some benefit. Now, you see an interest in making sense of things as older people get more interested in the arts and understanding human experience, and that may be part of trying to attain a sense of integrity. How does it all fit together and make sense? Now, that said, the older adult who is unable to do this, according to Erickson, then falls into a state of despair. They look back on their life and they say, nah, I just didn't make any sense. It was just, one stupid thing after another that didn't really go anywhere. I haven't achieved anything worthwhile, and now it's just too late to change that. And people just despair. And that's a sad situation to see a person that's in that state. Now, also, Erickson suggests that as the person gets older, they become more aware of the interdependence of the generations. They become aware that younger generations depend upon them to learn about various things that they have encountered, that younger generation looks to them for wisdom. And so again, that search for integrity also allows them to fulfill their role in passing on the knowledge and wisdom they've gained to other generations. Abraham Maslow also suggests new cognitive developments in late adulthood. At this time, the person may have new opportunities to pursue self-actualization, to strive to reach their best at whatever they're best suited for. And at this point, the older person, although they may have been very busy previously just making a living, now they have more time available, more resources than they did as well. And so they may begin to express themselves in ways that maybe they've postponed or that they couldn't afford due to lack of time or resources. They might take up things like painting or drawing or gardening, woodworking, playing a musical instrument to sort of express their potential in whatever areas have been undeveloped. So you might see some new abilities developing there. In fact, if we look at the art world, we see advanced creativity in late adulthood. For example, Grandma Moses, an elderly woman who began painting at a late stage in her life, and when others encountered her paintings, they became very famous. We also look at many artists, and the art critics will talk about their old age style as being their very best work. It's the culmination of a lifetime of creativity. So again, some people may reach their peak when it comes to creativity at this point in time. Musical composers, in many cases, the same way. So again, new developments. The person in late adulthood also begins reviewing their life, and that life review helps them to put it all in perspective and make sense of it all. And so memories of the past are revived, they reinterpret events, and they reintegrate these, try to fit them together into some sequence that makes sense to them. They try to gain insight into the significance of various events that were part of their lifetime. Now, one of the ways that they engage in this life review is that they tell stories to younger people. And some of you all might have heard some of those stories that they tell. And interestingly, you might find sometimes they tell that same story more than once, maybe numerous times. But if you listen closely, you'll also notice that frequently they sort of adjust that story and they tell it a bit differently each time. And that may be because telling that story each time allows them to reinterpret and process that event until finally they make sense of it and put it into a perspective. So in fact, as we listen to those older people tell their stories, we may be actually doing them a beneficial thing by listening. And not to mention that they want to connect the past with the future. They want to pass those stories on so that we can learn some of those lessons that they learned through those events. So that life review is not just all about themselves, but is also in many cases about passing on knowledge of the family, about their cohort, the group, the generation they were a part of, or to pass on elements of their ethnicity and culture that they see as valuable for the next generation. And this whole life review thing, rather than being a morbid thing that they're dwelling in the past, seems to be a natural healing process that benefits that older person's mental health. So this actually turns out to be a beneficial thing as they think back over their life. Some would also suggest that in late adulthood there is the material and resources now for the development of wisdom. Wisdom being a broad, practical approach to problems where the person has exceptional insight, exceptional judgment. Wisdom would include the ability to identify timeless truths rather than just temporary solutions. And you've got to admit it that older adults often have the ingredients for this. They've had a lot of experience. They have a well-developed knowledge base, especially in areas in which they've specialized. And at this point, they're able to put aside their personal needs to a great extent and reflect on what would benefit others. And they have time for honest reflection. And so of any age group, older adults have probably the greatest advantage when it comes to developing wisdom. Now that said, younger people may develop some wisdom as well, but it's just that that older person has the ingredients more readily available to become wise. So there you have it. I think that's the end, and that should cover it. The first part of the chapter, part 1, at least fall 2014, we did that at class. There is a part 2 that's previous to this one, and then this completes the chapter 14, late adulthood. Oh, there's something more. Sorry about that. Okay. How quickly I forget. I reviewed this just a minute ago. Gee, maybe I better get checked out, huh? Anyways, okay. Just threw in here a few other things. Characteristics of exceptionally long-lived groups or long-lived. Things that they found, even though these groups often were quite different from one another, there were some lifestyle things that were common amongst these people. One, in terms of their diet, they tended to eat a natural diet rather than processed diet. They also eat sparingly, not stuffing themselves, eating a lot less than we might be used to. And Their daily activity includes physical work, so they get physical exercise just in their daily existence. And also socializing with family, friends, and neighbors was a daily thing, very frequent that they engaged in. And then even beyond the physical work, there were other exercise that was available. For example, dancing and things like that, often part of those groups that long lived. And they also got adequate rest and relaxation, a break from stress frequently. So this is very typical of these people that live long lives. The centenarians are people that have lived 100 years plus. And this is actually the most rapidly expanding age group here in the U.S. and most of the developed world. And we see these centenarians, some of them are active, some of them are quite capable still, some are impaired, some impaired physically, some in terms of cognition. But that said, interestingly, even those who are impaired reported being relatively content and happy across the board. Centenarians seem to be a rather positive attitude kind of group. So maybe that also gives us some clues about attaining a long life, and maybe contentment and happiness also contributes. So there, I think this is finally the end, and the thing sure is long, so I'm going to stop. And good luck.